that looks perfect. We have 28 participants in the meeting. So Dr. Talebi, whenever you're ready. Thank you so much for coming today.
Hello, everybody, and thank you so much for the invitation. So today we're going to talk about the cardiovascular disease in women. So the point that to reduce the gender gap in prevention, diagnosis, and treatment of cardiovascular disease. So regarding cardiovascular disease, gender is really matter. Cardiovascular disease is the leading cause of the deaths in women in worldwide. Heart attack in women accounts for 1/3 of the all female deaths worldwide. Cardiovascular disease has a worse outcome and higher mortality in the women than men. Cardiovascular disease in women remain understudied, under-recognized, underdiagnosed, and undertreated. Risk is still underappreciated. In the survey that conducted by American Heart Association, they saw that day-to-day basis, women still worry about the breast cancer, but the heart disease actually kills 6 times as many women as in the year compared to the breast cancer. Many women say their physician never talked to them about the coronary risk factor and sometimes don't even recognize the symptoms. And if they have some complaint of the chest pain, mistakenly they are thinking that is a panic attack, stress, or hypochondria. Women's symptoms about the coronary artery disease can be completely different with the men. And also, women much likely than men die because during the cardiovascular disease during the year of having heart attack. So today, actually, the point that is mostly to review some of the cases. These cases actually come to our hospital. It can be Mount Sinai St. Luke's or Mount Sinai Morningside or Mount Sinai West. And let's see how we manage this type of cases to give you some idea how we still have a gap to manage this patient. The first case is a 39 years old. As you see, I put exactly the date the patient presented to the hospital. It was in January 22. She has a history of fibromyalgia, asthma, hypertension, and hiatal hernia, and also some history of lupus that the patient is on treatment. She complained of some chest pain. She had some symptom of the flu, and outside of the hospital, she went to the urgent care and she got some Tylenol and Motrin for the pain. Because the pain didn't improve, she comes to the emergency. Look at the way that she described the pain. She described a sharp pain that radiated to the mid-back. It's worse when the patient lying the flat and with a deep inspiration. And when she's sitting and leaning forward, actually the pain is getting better. Also, she had some vomiting. So see that if you put all information together, some of them typical, some of them atypical, and also the patient has some risk factor for coronary artery disease. The first step was the EKG. As you see, the EKG is normal sinus rhythm, no STT changes. So EKG didn't help too much. We checked the labs. You see the troponin was tiny, elevated for this patient. Patient has a positive test for the lupus. There is a mild increase of the CRP also for the patient. Because of the underlying risk factor, they decided to do the echo for the patient. This is the 2-chamber. You see the anterior, inferior is contracting very well. Then we have apical 3-chamber. Again, the contraction of the anteroseptal and infralateral is completely fine. And also in the 4-chamber, anterolateral, infroseptal, contracting completely normal. So basically, based on the echo, we find that patient has a normal ejection fraction, maybe mild LVH, and no significant valvular problem. For the complete workup, we decide to do the CTA for the patient. Calcium score was 0, and also the coronary was completely normal. So we get enough confidence. This patient looks completely fine. We discharge the patient and say that patient can be followed with a rheumatologist. After 2 months, the patient again back to the hospital. The same story, lupus, fibromyalgia, some risk factor. Patient come with a pain, chest pain. Actually, the quality of the pain was very similar to the prior admission. So she complained of some retrosternal chest pain, That's kind of getting worse when the patient lying down flat, and then actually leaning forward, the pain is improved. Also, she had one episode of the vomiting. This is the EKG. Based on this EKG, prior CTA, actually the ER decided to discharge the patient, but patient insists that, no, my pain is really severe and I prefer to stay in the hospital. Because of the pain comeback, so that's the first troponin when they checked in the ER, and the patient complained of another episode of the chest pain. Meanwhile, she was in the ER and they checked the troponin. Troponin trended up to 4.6. As you see, you have some dynamic EKG changes in precordial leads. You have a T wave inversion V2, V1, V2, V3. Then the T wave is become biphasic. So you have a dynamic EKG changes, and also in the AVL, T wave is become inverted. So we repeat the echo for the same patient. As you see, the apical part is a little bit hypokinetic. In the two chamber, again, apex doesn't contract very well. And in the apical three chamber, you see the part of the anteroseptal is hypokinetic. So last time, 2 months ago, ejection fraction was completely normal. Now we have a mild reduced ejection fraction and some new wall motion abnormality that was not there before. So, okay, we said, then maybe it's not a bad idea this time do some more investigation to see what happened for this patient. We did a cardiac MRI. This is the CNA images in the cardiac MRI. Unfortunately, I think the internet is a little bit slow. I can move these images. So as you see, everything is coming nicely except the mid anteroseptal. The MRI was done the day after the echo. So the apex was hypokinetic. The echo from the day before actually is getting better, but still the mid anteroseptal is hypokinetic. This is the, again, CNA images in the short axis. So the basal segment is contracting. And if I point here, you see is pale compared to the other segment because the contrast is staying there, and also it's hypokinetic. You have some tethering, but the myocardial thickness is not significant here in anterior wall. So the mid-ventricular of anterior wall is hypokinetic. The beauty of the cardiac MRI is if you do the cardiac MRI in the acute phase that the myocardial injury happened for the patient, you can figure out the myocardial injury. So we did the mapping for this patient. You see the same segment of the anteroseptal that was hypokinetic. We do have an edema in the T2 mapping, and we have a tiny subendocardial infarction at the same segments. So based on the patient's symptoms, history of connective tissue disease, possible of some coronary spasm, this time we discharge the patient with a high-dose calcium channel blocker. Again, here in the apical tree chamber, the same segment was hypokinetic. We do have an edema. Let's move on to the second patient. The second patient is a 50-year-old patient who came with a chest pain. Troponin was 6 and then 11. We did the echo for the patient. There was some degree of LVH with a preserved ejection fraction and no new wall motion abnormality. EKG, normal sinus rhythm, no STT changes. We did the echo for the patient. So here you see in the two chamber is completely anterior, inferior. Actually, that's the four chamber, anterolateral, infroseptal is contracting very well. This is your two chamber, anterior, inferior spine, and also the apical three chamber contraction is completely normal. We did a cardiac cath. In the cardiac cath, actually all the coronary was normal. There was a small diagonal that the interventionist was not completely convinced if it's some atherosclerotic disease or possible scat for the patient. So they decided to do the cardiac MRI to see where is exactly the myocardium has an injury. We did a cardiac MRI. This is the CNA images. So if you look at the four chamber, everything is contracting very nicely. But in the two chamber, you only see a small part of your anterior wall in the mid ventricle has a severe hypokinesia to akinesia. And here, apical three chamber is completely normal. Again, we look at the short axis images and the same segment, you see it's little bit, the contrast stayed there, so it's pale compared to the other segment. And also there is some akinesia of the hair. We give the gadolinium to the patient and we look at the scar. See, there's a tiny amount of the myocardial scar in the hair. So basically the diagnosis was at the end, it was a scat that caused some myocardial injury at the level of the diagonal. And definitely we went through the other study, look at the carotid Doppler, check for the fibromyalgia. We don't have any specific treatment for the follow-up for the patient that presents with the scat, unfortunately, but we at least figure out that patient, where is the myocardial injury happened for this patient. Let's move on to the case 3. Case 3 is a 50 years old patient. The first time the patient presented to our hospital was around October 2019. She had history of hypertension, obesity, fibroid, and the chief complaint was the chest pain. The pain was substernal, pressure-like, not radiating. Actually, she was working in a hotel, and then suddenly she had this chest pain and she comes to the emergency. The time she comes to the emergency, the blood pressure was very high, but she had a history of hypertension, and as per patient, she's taking the blood pressure medication in the regular basis. The EKG shows some mild increase of the voltage, some strain pattern in the 1 and AVL, and actually the serial EKG didn't show any dynamic EKG changes. Troponin was mildly elevated. Because of the risk factor, also we did the echocardiogram. There was a significant left ventricular hypertrophy, and ejection fraction was completely preserved. They mentioned mild aortic stenosis. This patient, cardiology was consulted, and they explained that increase of troponin maybe was because of a very high blood pressure, type 2 hypertension emergency. And I should mention for this patient, she never had history of coronary artery disease and the kidney function was normal. So when you put the mark of the type 2 MI for hypertensive emergency, you should make sure that you did all of the workup before you make this diagnosis for the patient. Recommendation was getting the CTA to see what's the coronary anatomy. And also because the blood pressure was very high, they recommend to look at the secondary reason for the blood pressure, and also they adjust the medication for the patient. Calcium score came back 0 in the CTA, and coronary was completely normal. So we told the patient, everything looks normal. You can go home and follow your primary care doctor for the hypertension. Patient come back after months to the hospital again. This time, again, the blood pressure was severely elevated. It was 247 over 144, but also the patient was complaining of severe chest pain, headache, and also severe chest pain. Because of the headache, they did the brain MRI, and they look at that the patient less than a month has a CTA, coronary was completely normal. So, and because the EKG also didn't show any dynamic EKG changes, and the amount of the troponin was very tiny, they gave the patient, okay, that's a type 2, it's a hypertensive emergency, your troponin is mildly elevated, but we already know coronary is normal, and the patient discharged from the ER. After months, patient come back again to the hospital with a chest pain. And also the blood pressure definitely was high. It seemed that patient was taking all of the medication that's supposed to take. EKG this time was more significant compared to the 2 prior admission. You have a significant ST depression in inferior leads. You have a ST elevation in V1, V2, and some ST depression maybe in the precordial leads. Because of dynamic EKG changes, they decided, and also they checked the troponin. Look at the last 2 visits that was happening 2 months ago. The amount of the troponin was not significant, but this time the patient has a significant myocardial injury. The troponin trended up to 48. The CAT was completely normal. There was a non-obstructive coronary artery disease, only less than 30%, the serous territory, they saw some lesion. This is the echo images. You see the LV chamber is very small. The patient has a significant left ventricular hypertrophy. This is parasternal. This is the short axis. Again, you appreciate the myocardium is very thick. The patient doesn't have very good echo window, but that's a four chamber. You see anterolateral, infraseptal, very huge papillary muscle. And also here in the two chamber, anterior, inferior is contracting. And this is the apical three chamber. Again, anteroseptal, infralateral is contracting very well. So basically, we read the LV so small, mark LVH, preserve ejection fraction, and no significant valvular problem. Because of the significant amount of the troponin, and they didn't find significant coronary artery disease, they decided to send the patient for better tissue characterization for cardiac MRI. This is the scene images. As you see in the scene images, maybe some small segment of the lateral wall looks hypokinetic compared to the other segment, but the ejection fraction for the LV and RV is completely normal. As I told you, we can look at the tissue characterization and myocardial edema. So we did the stirred images. When you have an edema, you see there is some part of you have an increased signal intensity. So I have some edema in the lateral wall here, here, and here. We gave the gadolinium to the patient. This is the axial images, again, two chamber, four chamber, three chamber, small LV cavity, and hypercontractile. Look at the LG. So we have an LG at the territory of the circ, and the amount of the myocardial injury actually is not very small. So part of the anterolateral and infralateral has acute myocardial infarction. The same segment was little bit was worrisome. It's the same as you see in the arrow is the part that the patient has acute myocardial infarction. So it seems that anytime the blood pressure was crazy high, actually there was some reaction to the severe chest pain, because anytime the patient comes to the hospital, the blood pressure was 200, 220, but also she was complaining of the pain 8 out of 10. So it was not really the blood pressure caused the increase of the troponin. That was a coronary spasm and some myocardial injury, and the severe pain caused that the blood pressure was become so elevated for this patient. So finally, the MRI was read some myocardial injury, suggestive of coronary artery disease, go with the territory of coronary artery disease. And again, this patient was treated with the nitrate and calcium channel blocker to prevent any more event of the myocardial injury in the future. And after they starting the nitrate and calcium channel blocker, the patient didn't come back to the ER again with the chest pain. Case 4 is a 63 years old female. As you see, the patient come to the hospital around July 2019. She had a history of hypertension, hyperlipidemia, diabetes, and she presented with some dizziness. They did the CT and MRI of the head. Everything was normal. Also, they checked the troponin. Troponin was mildly elevated. So the patient transferred from Mount Sinai to here for more coronary evaluation. As you see, the EKG has some increase of the voltage, a strain pattern. Troponin was tiny, elevated for this patient. Echo was read that ejection fraction is completely normal, a small LV chamber, and preserved ejection fraction. Finally, they decided to do the stress test instead of doing the CTA or the cardiac cath. This is the stress echo was done for the patient. The 4-chamber images, you see post-exercise, the contraction improved in all anterolateral and infraseptal wall. This is the 2-chamber, apical 3-chamber. Again, with the exercise, wall motion, everything improved and getting better. And also in the 2-chamber images, patient has a good response. So finally, it was read the good exercise tolerance, very good contractile reserve, and the patient got discharged. After 6 months, the patient come back to the hospital again. So history of hypertension, diabetes, and she complained of the left-sided chest pain, that kind of, and also the left arm pain that caused the patient woke up at midnight because of the pain. The scale of the pain was 8 out of 10. Actually, that time, the patient got discharged from the ER, sorry, because the troponin was trended up, the patient also did transfer to Mount Sinai Morningside for left heart cath and more evaluation. So we had a prior stress test 6 months ago. It was completely normal. But this time, we don't have any significant EKG changes, but the troponin trended up to 9. We did a cardiac cath. Nothing really impressive. There was a non-obstructive coronary artery disease, and also there was some atherosclerotic plaque in the LAD that was not significant. Echo was reported as a concentric LVH, preserved ejection fraction for the patient. We did a cardiac MRI. You see the patient has the hypertrophy of the heart, contraction, everything is okay, except this looked like as the inferior wall compared to the other segment is lagging and doesn't contract very well. We did the late gadolinium enhancement, and as you appreciated in the inferior, patient has some almost transmural myocardial infarction. Again, here, this arrow points to the part that the patient has a LG. So basically, the patient has acute myocardial infarction, again, with a differential diagnosis of possible vasospasm, emboli, or scat for the patient, or coronary dissection. Let's move on for the case 5. So the prior cases that I thought, it seemed that they have a very benign course. The troponin was mildly elevated, and thanks God, we pick up in kind of early stage with the cardiac MRI, and we started treatment. And after the treatment, so far, the patient didn't come back to the hospital because of the chest pain. Case 5 is a little bit more dramatic compared to the other cases. This patient has a multiple cardiology follow-up outside because of some chest pain. Every time they did the stress test, actually this patient has a CTA, was completely normal. So they told the patient, you're fine, it's chest pain. It seems that maybe it's a panic attack or something else, but doesn't look like that is coronary related. Finally, the patient on May 2018 come to the hospital. As you see, the patient has a past medical history of hypertension, asthma, obesity. Come to the ER with the chest pain. I'm going to show you the EKG. The EKG has significant EKG changes. So the STEMI code was activated during the time that the patient was in the ER. Patient went to the VFRS. So they shocked the patient, and directly from the ER, they took the patient to the cath lab to figure out what happened for the coronary artery. As you see, this patient, the troponin trended up to almost 93 to 82. So it's a significant amount of myocardial injury for this patient. EKG shows significant ST elevation in inferior leads and also ST depression in precordial leads. With a diagnosis of possible acute inferior posterior MI, this is the serial EKG. As you see, the Q is formed key wave inversion. The patient took to the cath lab. Interestingly, in the cath lab, they couldn't find any obstruction. And there was a small branch, it looked like has some spasm, and they gave the nitro, and the patient has a very good response, but the LVDP was very elevated. This is the echo after the cath. So here you see the anterolateral is a little bit hypokinetic. Inferior doesn't contract very well. Infralateral also is done. With the contrast, maybe it's easier to see the anterolateral. It doesn't contract very well. In the 2-chamber, you see the inferior is completely done. And apical 3-chamber, the infralateral has a significant hypokinesia. We did a cardiac MRI. In the cardiac MRI, as you see, this part is completely akinetic. This part is akinetic, and this part. So all of the inferior and the lateral valve has a significant valve motion abnormality with a significant drop of the ejection fraction for this patient. So here you see the part of the contrast staying in the inferior and the lateral valve. We did the first pass perfusion. So we give the contrast during the cardiac MRI, and you see this black area is the part that the contrast cannot reach to the myocardium, because you have a completely myocardial scar in these segments. So the whole inferior and lateral, this patient has a transmural myocardial infarction. So compared to the other cases that coronary was normal and maybe we pick up in the earliest stage, this patient has a significant myocardial infarction, unfortunately, secondary to the coronary spasm. So you see, almost half of the myocardium is gone. So you're talking about the 50 years old patient. She was complaining of the chest pain more than 6 or 7 months, follow up outside. They never figure out what's the problem. And now finally, the patient has a heart failure. And because of the drop of ejection fraction and also the VFRS that the patient has in the acute phase, finally she got the ICD. During the admission in the hospital, patient has another episode of severe chest pain. So this is the right coronary artery. The patient took to the cath lab, and in the cath lab, they gave the nitro. So you see that this is the huge RCA that has a significant vasospasm with a significant response to the nitro. So basically, the diagnosis was coronary spasm. Maybe if this patient was diagnosed, the time that she was complaining of frequent chest pain, and if we started calcium channel blocker, we could prevent this amount of damage of the myocardium for this patient. So let's move on for another patient. This is the patient, actually part of the minocarditis, with a 70 years old guy. He had a history of atrial fibrillation, but he's not taking his anticoagulation in regular base. Come to the hospital with some chest pain. They did a cardiac cath. Actually, the coronary was completely normal for this patient. We did a cardiac MRI. So you see the atrium is really huge for this patient. There is a biatrial enlargement. And between the cine images, the only segment looks abnormal. It's a small segment of the infralateral. So anytime the patient with the atrial fibrillation sometimes come to the hospital with some kind of chest pain, mild increased troponin, keep in your mind that patient is at risk of send the emboli to the brain that sometimes is presented with the TIA. Also, this small emboli can go to the small branch of coronary artery and cause the myocardial infarction, because most of the time we are saying that patient has atrial fibrillation, fast heart rate, demand ischemia. But there is a possibility that sometimes that emboli goes to the small coronary. And if you do the MRI in the acute phase, you can figure out what happened to the patient. In the cine images, again, you see some small part that doesn't contract very well. This patient also has a pacemaker. This is the artifact from pacemaker. And as you see here, I have a transmural myocardial infarction. So normal myocardium is nulling and it's completely black. And this whitish area is a scar tissue that you can see for this patient. So it's a type of minocardium that your coronary was completely clean, but the reason was the myocardial infarction was emboli to a small branch for this patient. Again, here in the inferior and infralateral, you see the patient has completely transmural myocardial infarction. That's kind of our last case. Is a 30 years old female. She had a history of precarditis. Since 2012, she has multiple ER visits with some chest pain. They diagnosed the patient with a possible precarditis, and always they give the patient short-term treatment, and the patient come back again with a chest pain. The patient presented to our hospital on November 2021, also again with some chest pain and mild increased troponin. This is the EKG. As you see, the EKG is a little bit low voltage, and you have some fragmentation of the QRS in the inferior leads. But nothing is very typical for the acute ischemia or precarditis for the patient. We check the test. There is a tiny amount of the troponin. This patient always actually leaking the troponin, and also the CRP was mildly elevated for this patient. We did a cardiac MRI for this patient. She's running, walking every day. So you see the LV size is a little bit in the higher side, but Left ventricle is kind of globally hypokinetic, and ejection fraction is around 45% for this patient. This is again the cine images. Globally, everything is hypokinetic, tiny precardial effusion, and EF was calculated 44% for this patient. We did a gadolinium. Look at the amount of the myocardial scar. So this black area is the myocardium, and all of this whitish area that I point with the arrow, their whole myocardial scar. So this patient actually was quote unquote was called as a pericarditis, but actually this patient has some type of cardiomyopathy that sometimes they have some episode of the chest pain that the troponin goes higher. This patient is follow up in my clinic, and always she's coming in the clinic when I check the troponin is mildly elevated. So she has a constant troponin leak and myocardial injury. When I get the more story of the patient, she has a sister with a cardiomyopathy. Also, in some point, her sister was candidate for the heart transplant. So anytime the patient comes with abnormal troponin, if you already have a patient with end-stage renal disease, 3-vessel disease, you know that heart failure, that's okay. The patient can have tiny troponin leak. But anytime the young patient, premenopausal patient, come with a mild increase of troponin, keep in your mind that we should do all of the evaluation to make sure we are not missing any diagnoses before we say that's the troponin leak. Because most of the time you can change the management and prevent of any more damage in for future for this type of patients. This is the long axis images. You see that a lot of myocardium of this patient, she's only 33 years old. This all whitish area actually is the myocardial damage. And now we start a discussion for the possible heart transplant and also the pace the ICD for this patient because of the amount of the myocardial scar and underlying cardiomyopathy that she has. So then you're talking the cardiac MRI. It's a very non-invasive test. Actually, there's no radiation. You're giving the contrast, the Gadavis, the new contrast we are giving. Usually we can give for everybody. No, actually, we don't have a specific limitations. As long as the patient doesn't have any contraindication for the cardiac MRI, like has any metal in the body, bullet in the body, cardiac MRI can give you some information of the function of the heart. You can evaluate for the ischemia. You can look at the origin of the coronary. And I think it's the most beautiful part of the MRI that it's completely unique with other cardiac imaging is a tissue characterization. So you can pinpoint where is the exactly myocardial scar or fibrosis, and also where is the acute myocardial injury happened for the patient. So when you're talking about the MINOCA, almost 10% of the patient that present with the chest pain, some might increase of troponin, actually they have a MINOCA. Is always is the diagnostic dilemma because we used to, if the patient come with the ACS, cath the patient, find the culprit lesion, and figure out what's going on. But unfortunately, some of the patient, 10%, and most of them, they are female, they have in the category of the MINOCA. And overall, the mortality in the first year can be very high for these patients. Cardiac MRI actually is a very good idea for these patients. So you can narrow down your differential diagnosis and you know how to manage this patient and prevent another event in the future. So if any patient come with a MINOCA, first you are looking at the patient has acute heart failure. If the patient has chronic kidney disease, Takotsubo cardiomyopathy, sepsis, pulmonary emboli with RV dilatation or myocarditis, they can cause abnormal troponin. This group of the patient actually doesn't go to the category of the MINOCA. MINOCA is the time that you have a small plaque erosion most of the time. You can have a coronary spasm. You can have a microvascular dysfunction. You can have a SCAD, a small emboli, or distal emboli. That most of the time, cardiac MRI can help you to figure out where is the myocardial injury, and then based on the result, you can go for the other tests. So that's the way that we usually recommend to approach this patient. So if the patient comes with the acute coronary syndrome symptoms and mild increase of the troponin, we want to see the coronary anatomy. So we do the CTA or we do the CAT. If we don't find anything in the CTA or the CAT, then we go to the other level. Actually, sometimes we should back and review the chart in more detail to see if we are missing something or not. First, we exclude the patient. They have a sepsis, they have a chronic CKD, CHF, or obstruct, the patient with the three vessel disease. If the patient is not in this category, then we will go for the more evaluation, that is echo. There is a possibility that you see the regional wall motion abnormality or the echo completely normal. This type of patient still will benefit from the MRI because you want to see, is this patient really has myocardial infarction? Does it go to the category of the menopause? Then you will go for the intravascular ultrasound or OCT, or you do some provocative test to see if there's a coronary spasm or not. Or the patient is simply a Takotsubo myocarditis or some type of, for example, hypertrophic cardiomyopathy. And if in the echo you see the RV dilatation, is the time that the pulmonary emboli should be ruled out for these patients. This is some of the example of the cases actually we had in our hospital. For example, is a 55 years old patient with a hypertension. She comes with a chest pain and some EKG changes. There was no significant obstruction in the CAT because we saw some myocardial injury in the MRI. The patient got the OCT, and you see the patient has a small, tiny plaque rupture. This is another patient. This is the guy, 75 years old, hypertension, present with the chest pain, some ST changes. As you see, the cardiac CAT didn't show significant lesion, but when we did the IVUS, we saw some small plaque rupture. And also we detected myocardial injury in the cardiac MRI. This is the lady, 70 years old, with a history of hypertension. She's super frail, a small lady. She comes with a chest pain. And the pattern of the echo actually was kind of suggestive of significant wall motion abnormality at LAT territory. The patient got the CAT. CAT didn't show any significant lesion. And when we did the cardiac MRI, actually it was a mid-myocardial enhancement suggestive of myocarditis. She also has a history of lupus. So basically it was a lupus myocarditis for this patient as a diagnosis. So you see that MRI can help you, that the patient should go to the category of menopause, not something else like as myocarditis as a diagnosis for the patient. This is another patient has one of the other reasons for the menopause is you have a emboli. It can be a paradoxical emboli sometimes. So patient come with a chest pain. We did a cardiac MRI. We find some myocardial infarction for this patient because of the RV dilatation and also the high level of QPQS. The patient get the transesophageal echo and the patient has an ASD. So basically the MI was the reason for the MI was the paradoxical emboli for this patient. And this is the case of the patient with the sickle cell disease. He presented to the hospital because of the chest pain and mild increase of the troponin. Cardiac CAT was completely normal, but because of the abnormal troponin, they decided to send the patient for cardiac MRI. And you see the patient has a small branch. This patient with the sickle cell disease, they are prone for hypercoagulated state, and they can send a small emboli to the coronary. So I think it's the beauty of the cardiac MRI because we do have some differential diagnoses in our mind, and we want to confirm the diagnosis. And if you do the MRI in the acute phase of the injury, that usually we have a window of the 2 weeks that acute event happened to the patient. If you do the MRI, you can figure out what's going on for the myocardium. Because, for example, if this patient come back to me after 2 months, if I do the cardiac MRI, maybe I will not find anything. The reason that we saw the whole edema, the small myocardial infarction, perfusion defect was that we did the cardiac MRI exactly the same time that the patient got admitted in the hospital because of the chest pain. This patient has an iron overload in the liver. You see the liver is completely reddish, but there was no iron overload in the myocardium. Thank you so much for your attention. If you have any question, let me know. Hello?
Fatma, do you have a
Hello.
question? Thank
Yeah,
you, Dr. Talebi.
I have one question. Thank you so much, Dr. Talebi, for this amazing lecture. I just have one question. So from all the presentations, do you think that Minoka is much more common in females, or it just happened by chance? And like everyone come with this atypical chest pain with normal echo, should we consider MRI?
So Minoka is more common in the female compared to the male because the most etiology for the Minoka is a plaque rupture. Plaque rupture is seen more in the female with not significant obstruction. The other reason it can be a scab and corneal spasm that significantly is more common in the female than the males. My discussion is about these cases I present to you is the female that come to the hospital with some chest pain. The EKG is not abnormal, but not significantly abnormal, but the patient has a tiny amount of the troponin. And every time we try to explain this troponin is hypertension, cause the troponin, or the patient has a precarditis. But at this point that the patient comes with a chest pain, you have tiny amount of myocardial injury, is the best time to do the cardiac MRI to figure out why the patient comes with a chest pain and make this tiny amount of the troponin. Overall, if you want to think about, because when you are talking about Minoka, you should have acute coronary syndrome to diagnose the Minoka. So it doesn't include the patient that coming as an outpatient for the chest pain. This is mostly the patient come to the ER with some chest pain, and we do not have any explanation for the mild increase of the troponin. But because MRI, usually I explain the MRI is not biopsy, it's the autopsy of the myocardium. So you see the whole myocardium, if there's any edema, any LG enhancement, then you can have the next plan to approach the patient. Because it's a workup, they just should be a start after MRI. MRI will tell this patient has myocardial injury because it's subendocardial, it's coronary related. Then the interventionist should back and take the patient to the cath lab and do the provocative test to see if there is a coronary spasm. Look at the IVUS or look at the cath result to see if there is a small scad or a small emboli to the distal branch that actually they miss it during the study of the cath for this type of patients.
That's great. Thank you so much.
Dr. Talebi, I would like to ask you a question if possible.
Sure.
Thank you so much for the talk. I just wanted to ask you if a patient comes with an acute coronary syndrome presentation, normal coronaries on the cath, and the MRI suggestive or diagnostic of myocarditis, would you still consider that a Minoka, or is that like a working diagnosis of Minoka, but in the end, you know that it hasn't been an actual MI?
No, the explanation of the Minoka is the coronary artery related. So the myocardial scar should be subendocardial at the territory of coronary artery. But when you do the MRI, if the diagnosis will be myocarditis or Takotsubo, actually it's not Minoka. So you exclude this diagnosis. But when you don't have an MRI, you don't know it's really is a Minoka or is a myocarditis. But the pattern of the scar is completely different. When you have coronary artery disease, the myocardial scar should be subendocardial. But when I have a myocarditis, it's a mid-myocardial or subepicardial enhancement. So that's a great, because MRI can exclude the other differential diagnosis. And you never, for the myocarditis, put the patient on DAPT, for example, and the treatment will be completely different. Yeah.
Okay, thank you.
You're welcome.
So just to confirm, so for those patients with Minoka, you sent them home based on the vasoreactivity. If they're reactive to calcium channel blockers or nitrates, we send them on that, and you send them on DAPT as well?
If they have a coronary spasm, like as the first patient, the last patient that has a significant myocardial infarction, actually the DAPT doesn't help. They should be on high dose calcium channel blocker and the nitrate. Yeah. Okay. So there is no point to give the DAPT. But if you see the plaque rupture, then that patient should be treated like as the other acute myocardial infarction, should be on that. For the coronary scat, unfortunately, still we don't have enough data what will be the best treatment. So far, we discharge the patient on aspirin, but we don't have enough data. The problem that most of this case is underdiagnosed and we don't know. So sometimes the patient comes, the frequent myocardial injury, and suddenly at the end, the patient has a heart failure and we cannot do anything for the patient. So the point that if we can prevent in the earlier stage, hopefully the patient doesn't reach that far. That's the reason that we have a very good improvement about the medical treatment for the ACS and everything. Still, we see the high mortality in the female because we compare the symptoms similar. We are thinking if the CAT is normal, the patient is benign, and we discharge the patient. As a cardiologist, still we are doing the same mistake. We have some improvement, but still we are not there. I think this is underusing of some other data and some assumption for the diagnosis cause that sometimes we don't treat the etiology very well.
And I'm sorry for this other question.
Sure.
So do you think that the MRI is giving us more data than the thallium scan?
Which type of scan? PET scan? PET CT?
Yeah.
You are thinking the micro, because another etiology for the MINOCA is the microvascular dysfunction. Actually, PET CT is more accurate. The things that MRI is great because show you where is the myocardial injury happen, if it's coronary related or not. After you rule out the myocarditis and Takotsubo, if the diagnosis is not plaque rupture or the coronary spasm, then actually you can do the PET CT to evaluate for the microvascular dysfunction, because microvascular dysfunction also can cause the MINOCA and also has a poor prognosis compared to the patient that they don't have microvascular dysfunction. And the good thing is that we have all of this modality in our hospital. We have a PET CT, MRI. I don't say that we should overuse this imaging, but sometimes it definitely can change the management for some of the cases. Any more questions?
It doesn't look like it, Dr. Talebi. I think you answered most of our questions, and thank you so much for
You're welcome. Thank you
that
for
great
the invitation.
information. Absolutely. Have a great rest of your day.
You too. Bye-bye.